This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. And we're now offering Category 1 CME credit through MyCares and Michigan State University. So if you need a little addiction medicine CME or CME for your DEA license, you can get it here. We put the links in the show notes. This week, we are going to be discussing e-cigarettes and how to use them or using them for smoking cessation. So how are you doing, John?
I'm good. How are you today?
Doing really well. Are you enjoying this warm weather?
Yeah, it's at 90 degrees, the early May here in South Central PA.
It won't last.
And you don't have AC at your house, right? You said?
We do not have AC. It's very warm here right now.
Okay, well, God love you.
So, John, what have you been thinking about in addiction medicine this week?
I had a really cool article that I saw that came across my inbox. It's from the New York Times. It's called Say Hello to Your Addiction Risk Score, courtesy of the tech industry. And it's from April 2024. And I think in a previous episode, we talked about the AdVerT. That's a genetic test for prediction of opioid misuse or possibility of developing opioid dependency based upon several kind of like genetic risk factors for opioid addiction and how that could be used as like a preoperative test. Well, this is actually about a product called NarxCare, NarxCare. And it's basically a proprietary algorithm that's integrated into some states' PDMP. And it kind of weighs different things like prescriptions, medical comorbidities, number of doctors you see, over what frequency. And it gives you basically a score, almost like a credit score, kind of predicting risk of opioid misuse or opioid dependence. And so it's kind of a tool that's meant to help practitioners determine or really kind of assess someone's risk of opioid use disorder if you were to give them a prescription of opioids. Clearly, incredibly controversial. The article really points out some very interesting facts, such as one, the product is proprietary. So while we know kind of roughly what's in the algorithm in terms of the individual components, we don't know how they're weighted. They also talk about how that some patients feel that the use of this has led to them not being treated adequately in terms of pain and appropriate indications. And I thought it was interesting that the product flags 20% of cancer patients as kind of very high risk for drug misuse. I thought it was like an interesting article, kind of more tools in our toolbox to try to somewhat validate our clinical gestalt as to who is likely to have an issue with a prescription. I'm not sure anyone that's kind of listening, if they have any experience with this or their state's PDMP has it. I know ours does not right now.
It would be really interesting to hear from our listeners if you've used this product before. What's hard for me to wrap my mind around, John, is like, I believe in risk scores. You know, someone who's high risk for bleeding, we don't give them blood thinners, at the same rate that we would give someone who's low risk for bleeding, or someone who's high risk for heart disease. I don't give them NSAIDs. And someone who's low risk for heart disease, I do give them NSAIDs. It's just hard because many of the factors that go into your risk of opiate use disorder are these very stigmatized things like race, history of incarceration. I mean, I don't know what's in the algorithm, but your socioeconomic status, your zip code, like where you live, all those things go into your risk of opioid use disorder or your family history. So it's like, should someone who has been incarcerated before receive different medical care than someone who hasn't? Because some of these risk factors are they're almost behavioral and socioeconomic. They're not genetic or medical. And so I get uncomfortable, differentiating care, but I can't deny that someone who has a history of opioid use disorder, a history of incarceration, who's a young man who has a, strong family history of addiction, I would be very, very hesitant to give that person opiates because I would worry about their risk of addiction. Whereas someone who doesn't have any of those risk factors, I would be less worried. So I can't say this scale is wrong. It does raise some uncomfortable questions about equity, I think.
Yeah, because somewhere, somehow, someone is looking at that score and going, like someone with an appropriate indication going, no, that score's high, I'm not prescribing. And I feel like, I don't know how frequently that's happening, but some doc somewhere is doing it. And one thing I thought was interesting, they talked about a person that they got flagged as very high risk because in their state, the PDMP picked up all their dog's prescriptions and their dog had a terminal illness. So it looked like they were kind of using all these drugs when really they had a hospice dog at home. And I thought that was kind of an amusing anecdote of someone that was erroneously flagged.
Well, all these risk scores come with like a little caveat that says, of course, clinical judgment should take precedence. And of course, you should talk to the patient before making any decisions. But of course, doctors and PAs and nurse practitioners and other prescribers, we're kind of simple people. And if the risk score is giving you a giant, like, red flashing light that says this person is at high risk, a lot of people just don't prescribe at that point. They set arbitrary limits because you kind of have to get through your day. And the scores do get taken as gospel and they do guide care. We'll see. I don't know. Is it coming to Pennsylvania?
I didn't see anything about that, but they said many states already have it. I've never heard of it before that. So I wonder how many states truly are integrating it.
I wonder if you did. You know how we can get data from PDMP from other states? I wonder if I would see it if I went to, like, whatever other state PDMP.
Maybe.
I'll have to look.
Experiment.
Well, that's super interesting. Thank you for sharing that. I'll put the link to the New York Times article in the show notes. I had something I wanted to ask you about, which was alcohol use. So usually we talk about opiates because that's the thing that you and I are both, sort of semi mini specialized in. But I was reading a report from the MMWR that came out recently about deaths from excessive alcohol use in the last 5 years. Actually, it's a little less than just the recent last 5 years. It was 2016 to 2021 because all this data is totally delayed. Deaths from alcohol use exceeded deaths from opioids, and they climbed by 30% during that 5-year period. So an incredible jump. So in 2021, 178,307 people died from alcohol use. And this includes deaths that are 100% attributable to alcohol, things like alcohol-induced pancreatitis. And it also takes into account causes of death that are partially attributable to alcohol use, like breast cancer, heart disease. So they don't include every single person who died from heart disease in the report, but I'm just going to make up the numbers. I don't know. But if they say 10% of heart disease is attributed to alcohol, they might put 10% of the heart disease deaths as alcohol related deaths. It's really high. And I just think we, as a medical community, I mean, we talk about alcohol more than opiates. Doctors are much more comfortable with alcohol use disorder, alcohol withdrawal. We know it's a common risk factor. We screen our patients for alcohol use much more comfortably and commonly, but I don't think we treat alcohol use disorder that well. And I've seen a lot of my buprenorphine patients this year struggle with alcohol. I had 3 patients who went to rehab and 2 more who were incarcerated due to alcohol use from my buprenorphine clinic in the last few months. And I've also had a bunch of people sneak in alcohol use disorder consults. They show in my schedule they're in the exam room, but they don't take opioids. They just want to talk about alcohol. So I feel like I'm seeing more alcohol as well. Is that something that you're seeing, John? More issues with alcohol use?
Like I have a clinic that I do medications for opioid use disorder, but I've always kind of had an all comers welcome that want help. So I've always had a substantial portion of patients there with alcohol use disorder too. And I think it's hard because you're right. We talk about a lot in medicine. We're really good at the acute care of alcohol use disorder, right? I think everyone knows about alcohol withdrawal, delirium tremens. I saw somewhere, I have to pull up the article, but they basically like polled, and I think it was family physicians about like, what's the treatment for someone? They gave a clinical vignette and they had alcohol use disorder. Like what treatment would you recommend? And it was like 90 some percent of people recommended the patient go to Alcoholics Anonymous, and they didn't kind of talk about standard of care medications. So I think we have a good idea of identifying it and we have a good idea of like treating it in the acute medical complication realm. But I think we undertreat it in terms of the disease by itself.
Yeah, totally. And I got to give props to the residents. They're always kind of ahead of the game. So I had 2 residents recently who were comfortable starting patients on naltrexone who came into office visits seeking help for alcohol use disorder. So go residents. They're doing better than the attendings. I get patients who come to me and they say, I went to my doctor and they said they don't give this medicine, so I have to see you. And that medicine is, naltrexone or acamprosate. So yeah, so keep your eyes out for alcohol, everyone. So, John, are you ready to talk about this article?
Yeah. So I have kind of a refreshing positive take on electronic cigarettes tonight compared to our normal bashing session that we give here. And this is a really cool article from it's electronic nicotine delivery systems for smoking cessation. It's from the New England Journal of Medicine. It's from February 2024. So a little bit of background. Electronic nicotine delivery systems, also called e-cigarettes, share many features with tobacco cigarettes, making them a very attractive potential for smoking cessation. And in many cases, I think this is how they initially market themselves as kind of smoking cessation aids for most patients. A sufficiently powered randomized control trial and a systemic review of randomized controlled trials showed that e-cigarettes were more effective than nicotine replacement for smoking cessation. When tobacco users quit smoking, smoking-associated respiratory symptoms such as cough and phlegm production are likely to diminish, but whether quitting with the use of e-cigarettes also relieves these respiratory symptoms is kind of a question that's still unclear. With few trials having systemically collected data regarding safety of use, the incidence of adverse events and serious adverse events associated with the use of electronic cigarettes is unknown. E-cigarettes deliver low levels of toxic compounds, much lower than that of conventional tobacco cigarettes, but few randomized control trials have verified whether e-cigarettes for smoking cessation are associated with a reduction in exposure to nicotine and other tobacco-related and smoke-related toxic substances. So, what do you think about e-cigarettes in your practice?
So plenty of people vape. I do have lots of patients who vape. I recommend it as a method of smoking cessation if you want as a nicotine substitution. So I recommend gum, patches, vaping, whatever as part of your quit attempt. But a lot of my patients who vape and smoke. So they vape when they can't smoke, and when they can smoke, they vape. So I see a lot of people doing both. I have very few people who use vaping as 100% method for quitting smoking. I just have not seen that be very successful. And I haven't seen a lot of people really try. If they really want to quit smoking, they're just saying, I'll just quit or I'll use the patch. How about you? Are you seeing a lot of e-cigarettes?
I see a lot of people that use e-cigarettes, especially younger people for the most part. And you're right. I think initially I was under the impression that most of the data showed that most patients that use these did not quit smoking. They just smoked and picked up a vaping habit too. But I think that like this article may show, and then kind of we've covered previously, there's a little bit of growing evidence that actually there might be some utility here.
Well, and I think there's definitely utility. I just feel that patients have to be using vaping as part of a quit attempt. If they're like, well, maybe I'll vape a little, that doesn't really make them quit smoking. But I mean, I think way back in the day when I was in residency, there was like a brand new exciting product, the nicotine inhaler, which looked like a little cigarette, which was sort of like an early e-cigarette, and patients were just clamoring for it for smoking cessation. And I remember it wasn't covered by insurance. It was very expensive. So I think people do want a way to quit. People want to quit smoking. And if it would work, that'd be great. But I'm not seeing a lot of people use it just for that.
So the clinical question here is one, how does the efficacy of tobacco cessation with e-cigarettes measure up against current standards of care? Two, what are the disparities in tobacco and nicotine abstention rates between individuals using e-cigarettes and those adhering to conventional cessation methods after 6 months? And three, how does the safety profile compare between individuals utilizing e-cigarettes for tobacco cessation and those adhering to the standard of care methods? So, study design. This is from the Efficacy, Safety, and Toxicology of Electronic Nicotine Delivery Systems as an Aid for Tobacco Cessation. It's called the Extends trial. It was an open label, randomized controlled trial at 5 sites across Switzerland from July 2018 to June 2021. It aimed to evaluate the efficacy and safety of e cigarettes when used alongside standard care compared to standard care alone in achieving tobacco cessation at the 6 month mark. The study population was adults aged 18 and above who smoked at least 5 cigarettes per day for at least 12 months, and they wanted to quit smoking within 3 days of enrollment. So, 5 cigarettes for at least a year, quarter pack per day for a year, and wanted to quit in the next 3 months. They excluded lots of people, pregnancy, breastfeeding, persons who used nicotine replacement or smoking cessation drug within the past 3 months, so recent quit attempt, persons who had regularly used e-cigarettes or tobacco heating systems in the previous 3 months. So basically previous use of these products in the past 3 months, either trying to quit smoking or using an electronic cigarette. So the procedure, it started with a pre-screen where basically interested participants were pre-screened by clinical nurses at each site to determine eligibility. And they determined at this initial pre-screen what your target quit date was. So what date do you actually want to quit smoking? At the baseline visit, eligibility was confirmed, consent was obtained, and then people were randomized in a one-to-one fashion to either the protocol or the intervention group. This was unblinded, and people were invited to the in-person clinic visits scheduled 6 months after target quit date. So basically, they had a 6 month follow-up date. And if they didn't follow up at the end of the trial, which was scheduled at this point in time, the nurse would try to outreach the patient. And if not, they would assume worst case scenario for data collection. For the control group, the trial nurse would give smoking cessation counseling, and that was kind of like a smorgasbord of smoking cessation techniques. So it was CBT, motivational interviewing, shared decision making. People were given the option of nicotine replacement, and they were also given the option of smoking cessation medication, so either bupropion or varenicline. Counseling was done in person at baseline, and then did tobacco cessation counseling follow up via telephone, and that was your target quit date, week 1, week 2, week 4, and week 8, kind of after the target quit date. You also got a 50 Swiss francs voucher for any purpose. And the idea was that, if you didn't get the study group, that you could use this to buy nicotine replacement, or you could use it at your leisure to do with whatever you wanted to.
I thought that was really nice. It kinda cracked me up that people got the study medicine and then everyone in the control group just got money to buy something nice for themselves as if, like, just being able to have something, did you need to control for that? I guess they felt like you did.
Yeah, I'll talk about why they did that. But yeah, they basically thought it control for any disappointment in the one group because, the study was not blinded. It's labeled as kind of a vaping or a e-cigarette cessation trial. So you kind of like let down when you found out you didn't get the e-cigarettes. So it's kind of a way of making them happy again.
Well, maybe making you stay in the trial. Maybe they thought people would just quit if they got randomized to get nothing.
Yeah, probably. So the intervention group was the same. So they had the same smoking cessation counseling, the same options for nicotine replacement, the same options for smoking cessation medications, and they got 2 e-cigarette start kits, 5 spare coils, and up to 10 e-liquid bottles. So they did counseling in person again at baseline, then telephone, target quit week 1, 2, 4, and 8. They were actually able to kind of sample at their discretion at the baseline 6 different flavors at 4 different nicotine concentrations. They could like mix and match for a total of 24 combinations. They said you could still try as many as you want. I feel like after I don't know, if you did all 24, I don't think you'd feel too well unless it was really like a long baseline visit, I guess.
It's a whole day of vaping.
Yeah. They were instructed to use the e-cigarettes as they desired throughout the trial. So basically, you could do whatever you want with it. Take the pen, and they also gave them options to order more nicotine replacement concentrations, and they could actually mix and match. They could switch their concentration and flavor throughout the trial. So if you selected like Tutti Frutti on day 1, you could switch to spearmint on like the 4th week in case you got tired, trying to eliminate fatigue of the product. They did data collection. So baseline and 6 months follow up was demographics, smoking history, smoking status, expired carbon monoxide levels, withdrawal symptoms, and respiratory symptoms. And they did the COPD assessment test for this. That's pretty valid, standardized test for anyone that treats COPD. Data collection occurred at target quit date, week 1, 2, 4, 8, and a 6 month follow up where the nurse documented adverse events and serious adverse events. At any point during the trial, a patient could call and report an adverse event. And then at the 6 month follow up, they also did a urine anabasine level. And I've never heard of that before, in all transparency. I had to look that up. And that's basically a urine test that would differentiate metabolites from a true combustible cigarette versus an electronic cigarette. So it's kind of a way of differentiating the two. What were the primary outcomes? So, is continuous abstinence from tobacco smoking at 6 months as measured by participant reports of no cigarette smoking after their target quit date with biochemical validation by an anabasine level of less than 4 nanograms per milliliter in a urine sample. And if that was unavailable, they would go off of the exhaled carbon monoxide level. So that was like their second best option for kind of like a biochemically validated abstinence. Secondary outcomes: sustained abstinence from tobacco smoking for 6 months with allowance of up to 5 cigarettes or a 2 week grace period after their target quit date, and abstinence from tobacco smoking in the 7 days before the 6 month follow up visit with biochemical validation and without biochemical validation, so reported and validated. Statistical analysis: the study used a log binomial regression model to analyze smoking cessation outcomes at the 6 month mark among trial groups. Sensitivity analysis was adjusted for baseline covariance and evaluated the impact of missing data on the outcome using inverse probability. So basically, they tried to kind of adjudicate for any missing data points, often kind of erring towards a more nullist outcome in terms of the data points. So, is this trial valid? First of all, not a bunch of industry bias here. So, this was funded by the Swiss National Science Foundation, Swiss Tobacco Prevention Fund, Swiss Cancer Research, and Lung Zurich. And I actually look at Lung Zurich because that sounded like a company. It's really kind of like almost an advocacy group in Switzerland for people with lung issues. So, it's more of a healthy air advocacy group. It was open label, randomized controlled trial of 1,246 participants. So it was a large trial, nice size. It really can't be blinded. So, it was unblinded, but that really isn't possible. I think even if you gave someone like a fake e-cigarette, I think they're going to know like the lack of nicotine component at some point. The authors thought that actually that was part of the reason why they gave the financial vouchers, basically to offset some of the participant disappointment from not getting randomized into that group. They could also use the voucher for wherever they wanted to, including e-cigarettes. So that wasn't like excluding you from the trial if you were in the control group and you bought an e-cigarette with your Swiss francs. It compared free e-cigarettes to a voucher for possible nicotine replacements and not to nicotine replacement itself. So I think the voucher was supposed to be like a potential. My question was the voucher used for cessation at all? And actually, they did get some baseline data about that and follow up data showing it was used often for this, not all the time. Data collection ended at 6 month time points. So duration of effect, I thought, was kind of unknown. So they are actively doing a follow up of this same trial at the 12, 24, and 60 month time points. So I think it would be interesting to see how these groups did over the long term, whether or not this device really was kind of a bridge for smoking cessation or whether or not it was more just a temporizing measure. More outcomes data was missing from the control group, from the intervention group. So basically, biochemical and patient reported validation was kind of missing from this group. So at a higher rate. So they did try to do statistical correction. They also kind of tend to assume that kind of missing data favored that they were worst case scenarios, so still smoking or not abstinent from either nicotine or tobacco. The study was conducted in the ambulatory setting, so the author cites that this limits use to other settings. And, I'd actually argue that I don't see a problem with that at all. I think that most tobacco cessation counseling and treatment occurs in the ambulatory setting. I don't think the hospital is the number one driver, or even close to the number one place where these services are provided. So actually, I think that, in a real world experience, I think that actually this is very reflective of where these services would occur. The endpoints were very relevant patient oriented outcomes. So tobacco use, nicotine use, safety, respiratory symptoms. As we'll get into in like the follow up, it was a little lighter in terms of the outcomes on the respiratory issues, which I think is very intriguing to me, especially as a primary care doctor. I have tons of COPDers that still smoke. Like, how does this fare in terms of that compared to smoking?
Yeah, I agree, and the data's still out as far as e-cigarettes go, and there's so many different kinds, it's hard to generalize, but there is concern about the respiratory effects of e-cigarettes. It probably can't be as bad as smoking, but it's still not great for your lungs, so especially if people might continue them long term, it would be good to know.
So, a little about the results. So, the study population 2,027 participants were screened, but only 1,246 were included in the trial. 622 in the intervention group, 624 in the control group. They were similar at baseline. Median age was 38. Most were men, 53%. Most were employed, 72.5%. The highest level of education was secondary education and 45.6%, tertiary and 46.8%. Median age of starting to smoke was 16. Median number of cigarettes per day was 15. Most had attempted to quit smoking before the study at least once, so 85.2% had already tried to quit once, just not within the past 3 months. The Fagerstrom test for nicotine dependence score was 4.3. I had to look that up. Have you heard of that before?
No.
That's basically a dependence score about like cigarette consumption and compulsion to use. And 4.3 actually isn't that high of a score. Like it's a score of 0 to 10. So 4.3 is kind of on the lower end there. The median expired carbon monoxide level was 20. The mean days till target quit was 6. So most people that want to quit like ASAP. 574 out of 622, that's 92.2% of participants in the intervention group, and 89.1% of participants in the control group completed the trial. All participants screened in the intervention group or control group were included into the final analysis. So even though 92 and 89% of the groups completed the trial, everyone was included, and they basically counted them as still using if the data was missing. Do you think that reflects your typical population for smoking?
Maybe. I guess I feel like my patients overall are older, so I see smoking cessation attempts in sort of older people. But yeah, the early start, the pack-ish a day, the many quit attempts previously. Yeah, I think so.
Yeah, I think so, with the exception that, this group is a little more motivated to quit than I think that my average person in a general clinic would be, like, because everyone wants to quit basically now, but that's selection bias for this trial. So, results, primary outcome. So, for biochemically validated continuous from smoking at 6 months occurred in 180 out of 622. So, that's 28.9% of participants in the intervention group compared to 102 out of 624, 16.3% of the control group. So, higher biochemically validated smoking cessation. And the adjusted relative risk was 1.71.
It's pretty good.
Yeah. And when you did an absolute difference between groups, it was basically 12.6%. So this was kind of effective in terms of comparing one to the other. This did make a difference, at least in this trial. Secondary outcomes in terms of continuous absence rates without biochemical validation that occurred in 237 out of 622. That's 38.1% of participants in the intervention group versus 146 out of 624. That's 23.4% in the control group. That's an adjusted relative risk of 1.57. Sustained abstinence, allowing for a 2 week grace period with biochemical validation, occurred in 30.7% in the intervention, 17.6% in the control group, adjusted relative risk of 1.7. Sustained abstinence, allowing up to 5 cigarettes with biochemical validation, occurred in 219 out of 622. That's 35.2% versus 109 out of 624. That's 17.5% of the control group, adjusted relative risk of 1.96. Absence within the previous 7 days with biochemical validation and 39.4% in the intervention, 21.3% in the control group, adjusted relative risk of 1.74. An absence in the previous 7 days without biochemical validation occurred in 53.4% of the participants in the intervention and 32.1% in the control group. That's an adjusted relative risk of 1.56. So basically, relatively similar across all domains where I was looking for. So, kind of whether it's biochemically validated or self reported, kind of outperformed the standard of care in all of these cases for patients in this trial, at least with the e cigarette, or at least on average it did. So, a little bit about adherence to smoking cessation therapy and e-cigarettes. So, just to give you a little bit of like idea, were they still smoking or were they just vaping at this point in time? So, in the intervention group, 95.5% reported e-cigarette use. So that makes sense. That was the intervention. 6.8% used nicotine replacement as well. Only 0.5% used smoking cessation medication. In the control group, even though they weren't given an e-cigarette, 3.9% did use an e-cigarette. Most, 63.6%, use nicotine replacement and 4.1% used a smoking cessation medication.
I'm kind of surprised only 3.9% reported e-cigarette use. I don't remember if you said, were they told to not buy e-cigarettes or they were told they could if they wanted to, right?
They could do whatever they want. That's kind of cool about it, right? Kind of like let people just gravitate to
Right.
what they would do.
I guess it's just interesting because these are all people who were probably interested, and that's why they signed up for the study in the first place. So I'm surprised more of them didn't just go out and buy the e-cigarettes.
That's a good point.
I don't know.
In terms of use of tobacco, e cigarettes, and nicotine replacement at 6 months. So at 6 months, 1,056 out of 1,246, that's 84.8% of participants reported use of tobacco cigarettes in the past 7 days, e cigarettes in the past 7 days, and use of nicotine replacement in the past 24 hours. So basically, most people were still using some form of nicotine. 59.6% of participants in the intervention group and 38.5% in the control group were tobacco abstainers, so not smoking any combustible tobacco product. And 20.1% of participants in the intervention group and 33.7% of participants in the control group were considered nicotine abstainers, so no nicotine containing products. In terms of safety, kind of going through this all in all, so both were very safe. I'm giving you like a high level bullet point here before I kind of break it down. So between baseline 6 month follow up, 4% in the intervention group and 5% in the control group had what they called a serious adverse event. That's a relative risk of 0.81 that does cross 1 on the confidence interval, not statistically significant. In terms of non serious adverse events, 43.7% in the intervention group and 36.7% in the control group reported some degree of adverse event. So, very common overall. And that was statistically significant, with more occurring in the intervention group with a relative risk of 1.19. 8.7% of participants in the intervention group had antibiotic use with 61 episodes of antibiotics, and 43, which is 6.9% of participants in the control group, reported 56 episodes of antibiotic use. I thought that was an interesting safety outcome, especially like a lot of people with COPD. We do look at kind of like frequent antibiotic exposure and kind of the harms that can be associated with that. And so it didn't seem to kind of make a substantial difference here. The last area was the respiratory symptoms. So the mean score on the COPD assessment test was 4.8 plus or minus 3.9 in the intervention group and 5.7 plus or minus 4.5 in the control group. So that's an adjusted relative risk of negative 0.66. Interestingly, when they actually broke down all these respiratory symptoms, they didn't include this to talk about, but there was a very long list of respiratory symptoms, all with minor reductions in the group that used the electronic cigarette over the tobacco. What do you think of those results?
I thought they were good. I really appreciated, like you said before, the inclusion of the respiratory side effects. I'd have to look through the other data. I guess the question is, how does it compare to other smoking cessation tools? To me, it seems pretty similar. Like if you look at trials of varenicline or nicotine patches or stuff like that, it's not a magic bullet. It doesn't come and like smack the cigarette out of your hand, but it seems like it does help a certain number of people quit. So I'm not shocked that it did. I'd be shocked if it didn't make any difference at all. And it seems like it had as good a effect as many of our other smoking cessation options.
I was kind of surprised a little bit that with this group being motivated to quit smoking, that such a small percentage of patients didn't use the medications as well for smoking cessation. I thought that was interesting looking back on it because they were given the option. You think that they would have combined both in a larger percentage, but it was relatively small, 0.5% in the intervention group and then 4.1% in the control group.
I wonder if it's cultural. Americans, we love our medications so much. Everybody wants medication at first as sort of a first line option. Maybe just this was Swiss, right? Maybe they're just not as comfortable with that.
I got a pill for that.
We'll make you comfortable. Come here.
So will this help me in patient care? I'm an outpatient doc. I this comes up all the time, and in full transparency, I live in a part of the country where there's a lot of people that smoke in my area. It's surprising to me how many kind of adults still smoke, even outside of my kind of addiction medicine practice. And oftentimes, I'll tell patients how much tobacco use is really affecting their health. So they often bring up the idea of quitting. Oftentimes, most people have tried to quit before, and most have had experience with a lot of our conventional measures, nicotine replacement, bupropion, varenicline. And, really they probably need to retrial some of these options, but they feel like they need to try something new. So this comes up all the time. I do think that this study shows that this does, as a harm reduction technique, does decrease the chances someone will be smoking cigarettes and does decrease the chance they'll be smoking cigarettes at all or consuming any form of nicotine. So it seems like overall it is kind of promising. I'm not sure that I'm going to jump to this as my first line option for smoking cessation, but it does seem like it's a promising thing. And especially we've covered now, this is the second article with pretty positive outcomes regarding using this medication to get off of nicotine and tobacco related products.
The other advantage to it that I see my patients in my addiction clinic, especially where they've all had experience with vaping, another reason they like this is it's very customizable. So I have a bunch of patients who actually, kind of like in this study, you can choose your nicotine at multiple strengths, multiple flavors, and people are kind of on their own personal smoking cessation program where they're slowly decreasing the nicotine in the vapes little by little so they can keep the vaping habit, but they decrease the nicotine. And so it just is really customizable if that's something that makes it easier for you.
Yeah.
Yeah, I mean, I really liked it. Thank you for presenting it to me. It does make me like I've really added e-cigarettes when I tell people what are their options for smoking cessation. I've added e-cigarettes in. I put it right up there. Do you want to try patch? Do you want to try varenicline? You want to try both? You want to try, Wellbutrin, bupropion? So I've put it in my arsenal, not as sort of a last resort, but as something you could try right off the bat.
Well, it's a good article. Thanks for talking about it.
Yeah, sure. So I don't have any talkback comments from our audience to share, but I do want to put out a call for opinions from our listeners. So we put out episodes a few weeks ago about articles that changed our practice. What articles were the most practice changing for us? And it was the most popular set of episodes we've ever done. People really liked them. We got a ton of downloads. So people listen to it, I know. And I want to hear what articles we've reviewed that have changed your practice as a listener. I'm just really interested. What are you doing? Did any of these articles or any article at all, even ones we didn't profile, change your practice? And if you have an article that changed your practice that we didn't profile, maybe we should know about it and we should share it with everybody else. So if you want to contact us, I'll collect the opinions and we'll see what article was the most practice changing for our audience. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media or join our Facebook group. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Aaron McHugh, CME support from MyCares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.